So we have a really important topic to discuss with you this morning on prescription drugs and access to it. Can I get you to bring up my slides? I want to preface this session with a little bit with a quick story from some work that we've been doing. So there's a medication for African Americans with heart failure, and a considerable amount of confusion around the medication. And there was a creation of an off-label set of drugs to mimic the drug that had cleared FDA. And the drug, this off-label use, was not sanctioned by FDA. It wasn't a generic drug. And it was literally off-label, meaning the physicians had sort of made it up. And they made it up because they believed that African Americans could not afford the branded drug. So we did a study. You know, if you know the National Minority Quality Forum, you know, we go into the data, we go into the history, and we wrote a paper that looked at the history of the off-label use and how the possible confusion could have occurred, with the intent to say, really quality of care is to make sure that African Americans received what was approved by FDA. And in the process of submitting that article for publication in a leading journal, this was no side journal, this was no out-of-the-way journal, this wasn't, you know, some of those dial a journal and if you pay me, we'll publish. If you go to the editorial board, these are people of standing in the industry. And so I've excerpted for you. There was one reviewer, and I've excerpted for you the comments from that one reviewer. And basically what that reviewer said was, hey, you got the science right. Yes, it's off-label use, and we have no quarrel with that. Our quarrel is the fact that we've decided that black people can't afford that medication. That was the reason why that paper was refused by the journal. The journal refused to publish the article based on, without any science, without anybody running the study, that African Americans could not purchase that drug. That means that you sitting out here in the room, if you went to a cardiologist with all of your degrees, with all of your status in industry or wherever you are, you could not get that drug. And the journal created a new standard. They created a new set of measurements. So you know me, I wrote back and I said, well, that's a peculiar rule. Have I misinterpreted? Are you actually saying that one of the standards in a journal of pharmacology is predicated on the fact that that person is black and can't afford the medication? Is that your judgment? And they wrote back with great indignity, yes. So you know us, we decided that let's go to the videotape. Let's take a look at some numbers. So I'm going to show you some quick numbers here. This is African Americans with chronic heart failure in the Medicare database in 2013. So it's pretty recent data. And we're comparing their out-of-pocket costs for prescription drugs against whites. Because presumably in Medicare, what we're looking at is the same out-of-pocket, right? meaning the Medicare premium pays for the drug, and what African Americans are paying for out of pocket is the medication. I'm going to walk up a little closer because my eyesight's I want to make sure I'm looking at the right slide for you. No, that's not the right one. I think it was. Here it is. So what we're looking at is that African Americans in the Medicare population, out of pocket, spend 51% less for their prescription drugs than whites. 51% across their medication. So if you've got chronic heart failure, you're a Medicare beneficiary, you're paying 51% less. And you would say to me, well, Gary Puckrein, why are you complaining about that? That sounds like a good thing. However, when you look at the hospitalization rates, what you find is that African Americans are paying more because they're going to the hospital more than whites. They're going to the hospital more. So when you put together the prescription drug data with the hospitalization data out of pocket, it means that African Americans with chronic heart failure pay more out of pocket than whites do, because the system has decided that African Americans can't afford drugs. That's what the system has decided. And this is not an isolated incident. If I take you through the diabetes data, you're going to see the same thing. So it's really important for minority populations to really understand what this conversation is about when we start talking about prescription drugs. Because there's a body of opinion out there that suggests, well, you can't afford it, so we'll just give you anything. And that anything may or may not work to the same effect. And guess what? Not only, because I can show you the mortality data, the hospitalization data, that means that you are not getting standard of care, that you're not getting the best that our society has to offer. So I give you that context to think about, because we are having this national conversation about access to prescription drugs. And I think you ought to have context for this. You ought to have a frame of reference that is looking at the world through the lens of what's actually happening to minority populations across the country. So with that, we think we've put together really an extraordinary panel for you. And so I'm going to ask Mike Ybarra. Mike, known him for a good little while. He's over at the at PhRMA, the Pharmaceutical Manufacturers Association. So Mike Ybarra, if you'll come up.
Thanks, Gary, and thank you all so much for having me. It's a great honor to be here. I have slides, if you wouldn't mind loading. I'm an emergency physician by training. I work clinically about a mile down the road at MedStar Georgetown University Hospital. I still see patients 1 day a week, and so this is an issue that I see from the lens of a prescribing physician and one that's working on the access, cost, affordability issues from the lens of the biopharmaceutical industry. And it's, we all face it. I mean, I know there are, a lot of physicians in the room. We face these issues from, hospitalization standpoint, from coming to the emergency department, from paying copays, on patients' prescription drugs. Affordability is an issue that our patients certainly face across the spectrum of healthcare expenses. And in the emergency department, we have this new kind of sense that we're feeling patient complaints increasing when they get their hospitalization bills. We call it the kind of bimodal distribution of complaints. We obviously hear from patients if something goes wrong. If they leave the department and they feel like we missed something, we hear right away. But as patients are experiencing more and more of their healthcare costs, we're also noting that about a month to a month and a half after the ER visit, we're seeing a huge uptake in complaints at that point, and that's because they're getting their bills. Patients are paying more and more out of pocket for healthcare expenses, drugs, hospitalizations, ER visits. And so people are faced with $1,000, $2,000 bills because emergency department charges are quite high. They're getting a physician charge and a hospitalization charge. And so we're noting that there are, patients are letting their voice be heard, whether it's from the cost of medicine to the cost of physician to the cost of hospitalization. And so it's something that I've felt clinically, because patients call me if they go to the pharmacy counter and their medicine's not covered. They want to know what other options they might have. And then we hear about it, a month to a month and a half later when they feel like their hospitalization charge was too high. They want to know, what did I get for that? And so this is a really timely conversation. It's something that I'm approaching in kind of both aspects of my life, the clinical aspect and the policy aspect. So I'm happy to provide an overview of what we as an association are doing, how we're thinking about this cost and value conversation from the prescription drug standpoint. And I will say I've really come to learn a lot about the term cost, because cost means different things to different people, value means different things to different people, and it's all very different from the question of affordability, because affordability is something very different and it's also very personal. So I'll go ahead and go to the first slide, if that's all right. I think nobody in the room would disagree that we're in an incredible time from a science standpoint. Medicines are clearly transforming the treatment of many incredibly difficult diseases. When I went to medical school, cure for Hep C was not part of the discussion, right? It was much more about the toxicity associated with the therapies that were currently available, and cure rates in the 50 to 60%. And so a lot of the current discussion is clouded in the fact that the industry has actually done a tremendous job from a pipeline standpoint of bringing new therapies to market, whether it's cancer, hepatitis C, immunotherapy. How many of you are local? Are there a lot of local folks here? So you all know that, Governor Hogan was he's a miracle in a lot of ways, but he's a Republican governor in a very blue Democratic state. And he was elected to office, and very shortly thereafter was diagnosed with stage 3B non-Hodgkin's lymphoma. And the assumption when people hear stage 3 or stage 4 cancer is that, that is typically a very bad prognosis. But what we saw was that 30 days after he completed chemo, he announced that he was in remission, and he's actually doing quite well. That is a highly treatable lymphoma. Our companies have focused tremendously in the cancer space. We've seen a 23% decline in death rates since they peaked in the early 90s, and 2 out of 3 people diagnosed with cancer are surviving to 5 years, which is a tremendous improvement. Former President Jimmy Carter is another incredible example. He was diagnosed with stage 4 metastatic melanoma. He was diagnosed because they found a spot on his liver. That spot was diagnosed as melanoma. He was found to have metastasis in his brain. He underwent therapy with a new immunotherapy, which is an incredible advance. It's something oncologists have been working on for 30 years, thinking about the right way to unleash the immune system on cancer. And it seems like we're really on the cusp of immunotherapies for a wide range of cancers. Melanoma is really the leading edge of that. And former President Jimmy Carter, stage 4 melanoma, patients that even 2 years ago tragically likely would have passed away in a short amount of time, announced that he is free of cancer. And hepatitis C, cancer, these are really high-profile, high-risk situations because they carry such high mortality rates. But even in the long term, our companies are really focused in chronic diseases as well, such as high cholesterol. You probably have heard of PCSK9 inhibitors. It's a great advance in lowering cholesterol for people that have familial hypercholesterolemia, a genetic condition that causes your cholesterol levels to be really high. They tend not to respond to statins, which are the medicines that a number of patients are on. Can I have the next slide, please? Thank you. Oops. So we've actually been here before. We are in a situation where last year there were close to 50 medicines that came to market that were FDA approved. That is a tremendous number of medicines. That means that these are new innovative therapies, oftentimes that come with a higher price tag than lower cost generics that have been on the market for some time. And so to a certain extent, we have a tremendous amount of success, but that also puts a lot of pressure on the industry, and then there are a lot of questions asked by folks in the room. But we've been here before, as I mentioned. We've seen headlines like we are seeing today in the wake of treatments and therapies for HIV. In the late 80s, the New York Times had a cover story that could have looked very similar to the way that we're talking about the hepatitis C therapies, which is that AIDS treatments were essentially going to break the economy. And what we found is that instead of breaking the economy, what AIDS therapies have done, they've changed it from an acute, life-threatening condition to one that's more chronic, manageable, and it allows patients to actually contribute to society because people with HIV are now, they're living with a chronic disease that's manageable, able to stay in work, to stay in their jobs, to live long, almost nearly a full life expectancy. And what that does is it actually increases kind of economic output. We have seen tens of millions of life years added, which allows people to contribute to society in terms of tax revenue. I mean, if you're thinking just from a purely economic standpoint, the benefit of keeping people alive and healthy is tremendous to the economy. And of course, from a just purely wanting to do the right thing, we obviously want these medicines. We want better therapies. We want the best therapies so that we ultimately have a cure. And right now, I think most people are calling HIV a functional cure. But we're talking right now about the cost and value of medicines because of what happened in 2014, and that's something that we clearly recognize. You can see here, 2014, there was a large spike in prescription drug spending in the 14% range, in terms of national health expenditures. But what people fail to look at is the time before that, and then what people project will be after that. And you can see in 2010 and 2012, prescription drug spending growth was close to 0%. It's well under total health expenditure growth, which was in the 4 to 5% range. You can see the blue line is national health expenditures on average, so hospitalization, physician fees, which tend to range in the 4 to 6%. Prescription drugs have more spikes and valleys, more peaks and valleys. You can see that 2014 was an aberration. Anybody know what happened in 2014? There was a cure for hepatitis C that was brought to the market. Hepatitis C affects millions of Americans, and so there were a number of people that were put on this therapy, cured of a disease. In addition, it was the first full year of the implementation of the Affordable Care Act. So we saw many more patients on Medicaid, we saw many more people in the exchanges, and they went to the doctor for the first time in 10 years, 5 years, couple of years. They were diagnosed with chronic diseases and they were put on a handful of medicines. And so we did see a large spike in prescription drug spending, but we've already seen that number come down, and the projections for 2015 are much more in line with the overall trend in healthcare spending. The other thing that you'll see in the headlines is conversations about increases that companies might put on the list price of the medicine. And this is a very complicated topic worthy of a lot of discussion. But the high point that I want to make, and I'm happy to dig in with you, please follow up with me, is that list price is not the final price paid. The list price is ultimately offset by significant rebates and other price concessions, whether it's a statutory rebate, like in the Medicaid program, where there is an agreement that companies have with the government to provide the best price on the market. And then there are other discounts, like the VA has statutory discounts. And then there are negotiations that occur in the market. So most of the negotiations occur through big PBMs like Express Scripts or CVS Caremark. They have tremendous leveraging power. They negotiate significant rebates and discounts off the price of medicines. And so you might see the list price as in blue going up, but you ultimately see that the invoice price, or that the ultimate price, is actually significantly lower than that in green. There's a big delta because of the negotiations that happen in the private market. And medicines are one of the only aspects of the healthcare system where ultimately the price will go down. There is a cliff eventually, and that's when a medicine goes off patent and becomes generic. You can see in 2005 the difference in what happened with two very important aspects of medical care, angioplasty or PCI, and the cost of atorvastatin. In 2005, an angioplasty was $47,000. These are hospital charges, so that was the hospital charge for a PCI, obviously a really common but life-saving procedure. And Lipitor was $2.13 per pill. By 2013, 2014, we've actually seen that Lipitor is now literally pennies, or atorvastatin is literally pennies because it's generic and there are a number of competitors in the market. It's 15 to 18 cents. It's a 93% decrease in the price. But we continue to see price climbs for PCI. Now it costs about $80,000 in terms of hospital charges to have a PCI. These are just common examples, medicines that are very frequently prescribed in this country. Lipitor, Diovan, common obviously for high blood pressure, Plavix, which is a blood thinner used in a lot of patients with heart disease, Seroquel and Zyprexa for mental health. And you can see that once a medicine goes generic, you tend to see the price drop significantly. Now, you probably are thinking there was a really high-profile case of a person who raised the price of a medicine several thousand%. That was something that we came out very strongly with significant concerns. And we have a proactive policy agenda on ways that we can address some of the challenges that patients are facing. One of them is reducing the FDA backlog. Because if a company right now wanted to enter the market that HIV kind of medicine or the infectious disease medicine that company raised the price of, if a company wanted to go in and compete, it would take them on average about 3 years to get that application through the FDA. So that's a significant backlog that prevents competition from entering the market and saying, hey, paying $1,000 a pill for this 60-year-old anti-malarial medicine or anti-parasitic medicine, is too much. We want to come in at a much lower rate. They're not able to do that because of the FDA backlog. So that's something that we have really talked about, and we want to get that addressed. I was asked to spend a couple of minutes on the way that the public programs work and compared to the private markets. And Medicare has two benefits for paying for prescription drugs: Medicare Part B and Medicare Part D. And that's very similar to what, if you have a commercial plan, would be your medical benefit and your retail pharmacy benefit. Part D in the retail pharmacy benefit includes most drugs, which are either picked up by patients at the pharmacy or delivered via mail order. Part B, which has received a lot of attention in the last couple of months because of a proposal that CMMI has put out there, includes a small number of drugs that are usually intended for a relatively sick population of patients. They're administered by physicians or other healthcare professionals in infusion centers or in the office. Medicare Part D, we think, is one of the more successful federal programs because of the way that it increased prescription drug coverage. You can see in 2005, only about half of seniors had prescription drug coverage. But post Part D, now we're upwards of 90% because it's really closed that gap. And it's increased adherence rates in the kind of early 2000s. 67% of patients had good adherence. Obviously, having access to coverage increases adherence generally. There's obviously a ways to go there, but we saw increase in adherence. And as Gary alluded to, medicines have the ability to offset spending in other aspects of the healthcare system. So, the clearest example is if you take Lasix and you have congestive heart failure, you keep the water off literally, then you're less likely to be hospitalized. If you skip a couple of doses of Lasix, then you may end up hospitalized with a congestive heart failure exacerbation. So people that take their medicines tend to be able to avoid hospitalizations for common conditions. We think Medicare Part D is a particular success story because it has come in well under budget. The original budget projections had it at upwards of $700 billion, and it's come in $350 billion less than that in the 10-year program. You can see Peter Orszag's quote that the bids are coming in, prices have come down much better than anticipated because of the competition that occurs in the private market. And in terms of the competition, these are the top 5 purchasers of prescription medicines. These PBMs, the pharmacy benefit managers, they're not just buying for Medicare patients, they're buying for all patients because Express Scripts or CVS Caremark, they are taking care of the contracts for commercial plans and for the Medicare Part D plans. They bundle all of these plans together. They negotiate for the best price. So they have tremendous purchasing power. Express Scripts, for example, I think they represent about 80 million covered lives, and the whole Medicare Part D population is around 40 million covered lives. So they are taking care of and negotiating on behalf of the vast majority of Americans. And it's important to keep in mind that those PBMs often negotiate on behalf of patient populations bigger than most European countries. The difference between what European countries do and what we do, they set price controls, right? They set a cap. They set a statutory cap. We have examples of the government setting prices in prescription drugs, and I alluded to those earlier. That is in the Medicaid program where you have this contractual best price, and then the VA program, obviously, which has the special price owing to the fact that these are, of course, veterans. So these are just some examples of ways that we want to promote access and the ways that the Medicare Part D program controls costs. Promotes access by allowing patients to choose their plan. I think that's particularly important for all patients, but if you have a medical condition, you want to look up and see, is my medicine covered? That's something that you can do in Part D, and if you don't like your plan, then you can change. There's not a national formulary. There are dozens of plans in every state, so you get to pick the plan that's right for you. It controls costs because these are private plans that are having the PBMs, which represent a spectrum of patients, not just within Part D. They're representing patients outside of Part D as well. They utilize that negotiating power, and they come up with this price. And just in the final minute, I just want to spend a second on Part B, which is the outpatient, or which is the infused medicines. These are the centers where you might get access to medicines of Part B. Hospital outpatient departments, patient's home, a dialysis center, or a physician's office. And physicians get reimbursed based on a statutory formula, which is the average sale price plus a 6% add-on. And I'm bringing this up because there have been proposals to change this add-on. One is currently being looked at by CMMI, and there's been significant concern expressed largely by physicians. The American Society of Clinical Oncology, Community Oncology Alliance have come out concerned about this. I'm thinking it's likely not the right approach to address patient access and affordability concerns. That this is likely a payment cut for physicians that will impact access to community-based therapies. You can see that ASP, the average sale price of these infused medicines, has actually stayed below the medical consumer price index. The blue line at the top is the overall medicine inflation rate, and then the green is the weighted ASP below that. So obviously, we recognize that there are tremendous changes in the market. We're moving to value-based insurance design. Physicians are having to work under clinical pathways, accountable care organizations, and providers are at risk for the cost of medicines. We're seeing that in some of these new payment models, providers are they are having to take into account the cost of medicines. And so we're obviously looking at that and looking at ways that we can better work together with physicians in alternative payment settings. But we really think that medicines are part of the solution. We don't think that we're part of the problem. We think we have the ability to bring new medicines to market that will help patients live longer, healthier lives. Because medicines have the ability to offset spending, that's one of the unique aspects, and over time, their price will go down when a medicine goes off patent. We saw that with the examples that I gave earlier. So I really appreciate your time, and I'd like to turn it back to Gary now to invite the other speakers. Thank you.
Thank you, Mike. I'm going to ask Kraig Kinchen from Eli Lilly to come up, please.
Thank you. So the issue of drug pricing has certainly attracted a great deal of attention, particularly recently. And the topic is obviously and understandably of great importance to a range of stakeholders in the healthcare system. Certainly patients who are concerned about the affordability of medications, physicians who on a daily basis are making treatment decisions, payers who are working to really understand how to best assess the value of medical innovations, policymakers considering a range of ideas in hopes of addressing this issue of the affordability of medications, and certainly organizations like the National Minority Equality Forum working to improve the overall quality of care for patients in a variety of communities. So at Eli Lilly, as a pharmaceutical company, we also recognize the importance of this topic, the importance of this issue of the affordability of medications. And so I'm thankful for the opportunity provided by the NMQF, for the opportunity to really participate and engage in a dialogue on what we think is a very important topic. Next slide, please. So the reality today is that there are many patients who really are struggling to afford their medications. It is also true that medical innovation is one important way to help to address the healthcare needs that people have today and that people will have in the future. So certainly when you think about conditions like HIV/AIDS, rheumatoid arthritis, cardiovascular disease, medical innovation certainly has contributed a great deal to progress in those areas, and a great deal of progress is certainly still needed in those areas. There are other conditions, lupus, muscular dystrophy, and others, where the really medical innovation has been much more limited and where patients really are still waiting for answers. So we believe that both issues are important, affordability and innovation, but we don't believe we can address these issues unless we figure out ways to make the healthcare marketplace work much more effectively than it works today. Next slide, please. So when we think about drug spending, if we think about retail prescription spending in particular, it represents about 10% of healthcare spending. And that percentage has really remained about the same for decades. Next slide, please. So why then this focus on drug pricing? And I think there are really a number of reasons why drug pricing has gained increased attention recently. But one of those is certainly this is an area that patients really feel. So if you think about out-of-pocket spending, about 20% of out-of-pocket spending, when you think about prescription drugs, patients will spend about 20% of that cost. If you think about something like hospitalization, they'll shoulder about 5% of the cost. So when you think about prescription drugs and the cost of prescription drugs, this is certainly an issue that hits home for many patients. So I will not pretend that I have suddenly become an expert in the complexities of drug pricing. I am from the drug development part of the organization at Lilly. So what I have learned in talking to colleagues and reading up on this issue is something that the previous speaker talked a bit about, which is that the list price is not the actual price. So just like few people pay the sticker price on a car, and you likely did not pay the price listed on the back of your hotel room door, rarely do patients pay the actual price, the list price of a pharmaceutical product. And so a lot goes into the actual price that is actually paid for that product. Next slide, please. So one of the reasons that different prices are paid is that the price may vary across the different markets within the healthcare system. So there are really four markets: Medicaid, taking care largely of the economically disadvantaged, Medicare Part D, and then Medicare Part D for physician for infusions and physician-administered drugs, and finally a large segment, the commercial insurance area. Within those segments, there are negotiations that take place. And because of those negotiations, rebates and discounts are offered. So at Lilly, when we looked at the actual prices that we offer in the U.S., when we look at our net price, that net price in 2015, for example, increased by about 5%. Next slide, please. So this was a slide also shown by the previous speaker, so I won't sort of belabor the issues there, but I want to just focus on one issue, which is that when we think about drug pricing, we have to think about it within the context of a changing payer environment. So the PBMs, for example, if you look at the top 5 PBMs, they now represent about 80% of market share. So when you think about pricing negotiations between drug manufacturers and PBMs, for example, there is a significant leverage that the PBMs have in these negotiations. Next slide, please. So also, when we think about drug pricing, we in drug development recognize that while there are incentives to move drug development forward, as part of the life cycle of any innovative product that is brought to market, there will be a time when generic competition can be introduced. And once that occurs, the price of that therapy drops dramatically. So this slide is looking at expenditures or payments for Medicare Part D, for example. And you see really the daily cost of care for the top 10 therapeutic classes in Medicare Part D, and how much that price or that expenditure has come down since 2006 and is projected to come down even further over the next few years. Next slide. So this slide really looks at what patients are willing to pay across various disease states. And really the only reason I show this slide is to, I think, demonstrate that patients do perceive a value of pharmaceutical products in a number of areas. I think it also speaks to the fact that there remains significant unmet need in a number of areas where really medical innovation can play a significant role in helping to address some of these issues. So what can we do? So certainly over time, we have tried to help patients, as pharmaceutical companies, we have tried to help patients directly pay for their medications. So that comes in the form of patient assistance programs. It also comes in the form of copay cards to help defray the cost of the copays. That has been going on for years. That will continue to go on. I think what you're interested in is, well, what else will pharmaceutical companies do? How else can we play a role in being a solution to this problem? So I think the first thing is something I think that is taking place today, which is I think we have to be willing to engage in the conversation with a variety of stakeholders to try to address this issue. So I think we can certainly explain our perspective. I think it is more important that we listen to the perspectives of various stakeholders in the healthcare system to better understand where we might have common ground to help to put forward some solutions for this issue. So one recent example is an initiative that Lilly undertook with Anthem. And so leadership at Lilly and Anthem started having conversations trying to find common ground. And so thus far with this initiative, there are really two areas of focus. One is on communication. So before a drug is approved by the FDA, there are concerns about the level of conversation that can take place between the pharmaceutical manufacturer and the payer. We believe it is important for those types of conversations to take place, and from a payer perspective, when they're thinking about planning for their expenditures, if they don't have really good understanding of what that drug is about, what the data are, what size of population will be covered, what's the potential price of that drug, it is very difficult for payers to do that sort of planning that is necessary. The second issue is, I think there's been a lot of attention on value-based contracting, so that the price of the drug that is paid for by the payer will depend in part upon the outcome that is achieved by the patient. So I think many of us feel that that is a very important advance when we think about how drugs are priced. In order for that to take place, in order for that to really flourish, I think there are a number of changes that need to be made in policy to really be able to facilitate that advance. Finally, I think pharmaceutical companies have to contribute to the efforts to prove value. So if we talk about the importance of assessing value, what is the evidence base that we are using for those value assessments, and how do we contribute to that evidence base? So, and I think this starts with clinical trials. So as we determine endpoints for our clinical trials for drugs in development, we not only have to think about the regulatory barriers, what do the regulators want to see to be able to have that drug approved, we also have to think, what are the endpoints that are important for patients, for physicians, for payers? And I think that can only come about through good conversations with those various stakeholders so that we have the appropriate outcomes in our clinical trials. I think beyond that, I think we have to also think about other forms of evidence that can be used to inform this assessment of values. So when we think about large databases, for example, trying to think about how drugs are utilized, thinking about how we evaluate the effectiveness of drugs, we really have to make advances when we come to some of the technical aspects of health outcomes research. On a related note, when a pharmaceutical manufacturer believes that we are going to introduce a product that might offset costs in other areas of the healthcare system, so decreasing hospitalization, for example, it's important that we contribute to the evidence base that tells that health economic story, and that other stakeholders in the healthcare system will see that research is transparent and are able to trust those results. So I think this is really the beginning of a continuing conversation that we need to have. I think it's important that we continue to engage in this topic and look for common ground, and I certainly look forward to your questions.
Our final presenter will be Quardricos Driskell. He's Manager of Health Policy and Federal Affairs at the National Psoriasis Foundation. Quardricos, please. The 40s.
Good morning. So I come from this perspective of cost and access, obviously from the patient perspective. As Gary mentioned, I am the Federal Affairs Manager for the National Psoriasis Foundation, where I manage all of the federal policies relating to individuals who are affected by psoriatic disease specifically. But I am also come in this role as the co-chair of the Coalition for Accessible Treatment. As many of you all know, for the majority of disease states in this country, gone are the days here in Washington of disease-specific legislation for the most part. And so we work a lot in coalitions to address this issue of access and cost and really also value. And so representing the Coalition for Accessible Treatment, which is a coalition of about 30 patient and provider groups to really address this issue of cost. But I come at the role this morning more so representing yet another coalition to which the National Psoriasis Foundation and 19 other patient groups are a part of, and that is the Patients for Biologic Safety and Access. And that is an organization that's composed, again, of all patient groups to address this issue and hear the voices and concerns of patients, to address the issues of the FDA as it relates to this new category of drugs called biosimilar, which will have a huge impact on issue of value and pricing. And so with that, what we have found, many patient groups, is that there are a large number of physicians who are not aware of these new drugs that are coming to market. And so with that, I just want to go through these slides. Next slide, please. Biologic basics. What we have to understand, next slide, please. What we have to understand about biologics is that biologics are highly complex molecule drugs that are used to treat a variety of diseases. They are not simple, complex drugs. They are highly complex, they're highly molecule, they're highly specialized. Biologics treat a wide range of diseases, anywhere from autoimmune to AIDS, HIV, as well as cancer. It's also important to note that biologics are medicines that are made from living organisms and are far more complex to develop and to manufacture than traditional chemical drugs. So when we think about this issue of biologics and what that means, what is really key for many of our patients is access and safety and efficacy. Changes in therapy can impact disease stability. It's important to note that specifically in autoimmune diseases, psoriasis specific, that changes in therapies can lead to immune responses and the loss of efficacy. Specifically for psoriasis, individuals who have psoriatic disease and psoriasis, what we do know is that it takes them years often to be diagnosed due to many misdiagnoses, and it takes them years to develop the right therapy. Once they get on the right therapy, there are a number of triggers that can cause their psoriasis to essentially not work, and thus what happens is that once their psoriasis doesn't work and once these drugs are no longer effective, it takes additional years to find the right therapy for many drugs, and this is the issue for many patients across disease states. Biologics are grown and not made. Again, very different than most generics. Biologics are not small molecule drugs like most chemicals, but indeed they are patterned after proteins and they are highly complex. And because they're highly complex, what we know is that we want, of course, these drugs to be safe and efficacious for many of our patients in our various communities and states. What's also important to know is that the FDA has also been engaging this issue of biologics and biosimilars, to which I will talk more in a minute, because they also understand that these drugs could have a huge impact on treating diseases. And so we, as the Patient for Biologic Safety and Access, have also been engaged with the FDA, as they've also been engaged with Congress on these drugs. Biosimilars. It's important to note, as we are experiencing, that biosimilars are highly similar to a particular biologic, but they are not the same. It's like a snowflake. Biosimilars cannot exactly replicate the reference biologic. And it's important to note, because these drugs, most people tend to think that biosimilars are just the generic form of biologics, and they are not. Biosimilars are not genetic biologics. Again, just to repeat and reiterate, biosimilars are not generics. Biosimilars can never be the exact copy of the original reference product of a biologic. And so it's important to note that. And that is the concern for many within various patient communities. And what we do within the various coalitions that NPF as others belong to is try to educate our patients as well as our provider communities, ensuring that biologics are not generics and they're not the generic forms of a biologic medicine. Switching is largely important for our community because the patient's concern is that the extent that evidence needs to be required to ensure that a biosimilar should be indicated on a case-by-case basis. Each disease is completely different. Even in my own disease state of psoriasis, a person who has psoriasis is different from another individual. It is very individualized, it is very specific. And so it's important that as providers begin to think about these new biosimilars that are coming to market, that you don't switch them from one patient to the other, but that research and evidence is needed on a case-by-case, on a disease-by-disease basis. What's also important to note is that in the issue of interchangeability, once a patient is on a certain biologic, and as more biosimilars come to market, that if a doctor or provider switches them, it can cause their disease states, in addition to the comorbid conditions more often than not most patients have, to completely cause an autoimmune response, which delays the chronic condition and worsens in many respects the chronic condition that patients face. And so it's important to note and to educate providers as well as patients again about the difference between biologics and biosimilars. Current policies and market factors are increasing the likelihood of switching for stable patients. There are a lot of unknowns from physicians to patients to pharmacists who might be confused really about biosimilars as they come to market. And because of the confusion, there might be a lot of providers who might be more than willing to switch a patient from a biologic to a biosimilar. And also what we potentially are concerned with is that insurance companies, insurance and pharmacy benefit managers will promote switching in order to cut costs and to increase profit, which of course, as we know, would be dangerous to the patients. We, of the various disease states that we are representative of, are making sure that the doctor and the patient continues to make the decisions about their health care. Increasing the number of biosimilars on the market could leave physicians and patients and pharmacists, again, to a lot of confusion. And so part of what the Patients for Biologic Safety and Access is to educate providers and to educate patients on this issue of biologics and biosimilars. As of now, there have been 2 biosimilars approved in the US. Obviously, one for our disease state, psoriasis, in addition to rheumatoid arthritis and other autoimmune diseases. And then, of course, there was one that is a biosimilar to Neupogen. And so we are engaged on this issue. And as these 2 biosimilars have been approved at the FDA, we look to more biosimilars to be approved for our patient communities. Lastly, as I mentioned, insurers may promote switching to cut costs and increase profit. Obviously, this is a concern for all of our patient communities, and we are also engaging with insurers to ensure that this is not the process, that this is not the case, as we look to educate all on this issue. Biosimilars from a policymaker's perspective. Obviously, what we do is representative of millions of patients across the country, is to educate members of Congress about these issues of biologics and biosimilars. So as a part of the ACA, Congress enacted the Biologics Price Competition Innovation Act, enabling the authority of the FDA to review and approve biosimilars. We have been engaged in Congress on both sides of the aisle on ensuring this issue of patient access and patient stability and efficacy. The FDA has implemented their concerns to address patient access. We have expressed our concerns and issues to the FDA as we continue to meet with the FDA on this issue of patient access regarding one-time switching, which is a concern for many of our patients. And we also have talked to the FDA about making sure that providers and patients continue to be educated as more biosimilars come to market. And one thing that patient groups, again, that we have done is really educate. We've educated members of Congress. We continue to write op-eds in various Washington-based magazines and newspapers. We continue to meet with Congress regarding this issue of biosimilars and biologics and making sure that people understand that our patients want therapies and our patients need therapies, but they don't need therapies that have not been approved or that are not indicated and tested for their safety and efficacy in making sure that each disease state, that they're specialized and indicated for each disease state. And we will continue to meet with FDA and work with Congress on this issue. And lastly, we continue to build upon awareness, working with the Alliance for Patient Access, working with the several other patient groups here in Washington or across the country on this issue of biologics and biosimilars and addressing this issue of costs. And I look forward to your questions. Thank you.
Thank you. So we have some microphones in the audience, and so I invite you to come up if you've got questions. We have a few minutes for questions, so please, if there are any questions. Please, use the mic.
Suzanne Du from Howard University College of Nursing. Could you please show us the last slide? Because I feel like that's the most important part that can complete the presentation, the last slide of the last presenter. What's our part? What we have to do? What can we do? So if we can look at it, it would be great.
Please. Okay.
Well, while the slide's coming, I think that's a great question. One thing that you all can do is certainly educate your members about this important issue of biologics and biosimilars. And when I say members, I'm specifically talking and referring to members of Congress as well as members of the General Assemblies across the states. There's a lot of education that needs to be done about these highly complex molecule drugs known as biologics, and then, of course, as the FDA continues to approve more biosimilars. So I would say really educate elected officials about these issues and about this debate to ensure patient access to really safe medications. Also attend and promote educational events. Certainly we are delighted and happy that the National Minority Quality Forum has invited the patient voice to sort of educate providers really about this issue. And I'll also just make your voice known, loud, and heard. And lastly, I think one of the presenters also mentioned about stakeholder engagement, right? We need for providers across specialties to engage patient communities, to engage these patient access organizations, advocacy organizations who work with their patients and who are engaged in these issues of biologics and biosimilars, as well as costs on a daily basis.
Thank you very much for the presentation. I'm Noel Cayo, Clinical Cardiovascular Research. My question is, when is it appropriate to switch from biologic to biosimilar, and how to assess the benefit or the harm, and to assess which patient would mostly benefit from switching, and what is the price difference between the two products?
So I'll address your last ending of your question. We are cautiously optimistic that biosimilars will have an effect on cost, a positive effect on cost in terms of lowering the perspective of what a biologic costs now. We know that many biologics are placed on specialty tiers. Many of those specialty tiers range from specialty tier 3 or higher, which, for an average patient, they're paying anywhere from $600 to $5,000 a month for medication. So we're optimistic that biosimilars will, in many respects, lower costs. The concern with switching is, biologics, again, are highly complex and they are highly specialized molecule drugs. And so they are not the exact same of a biologic. So if a provider happens to switch from a biologic to a biosimilar, we're concerned from a patient perspective that depending on the disease state, it might cause significant damage and an autoimmune response that we're just not aware of. And so what we would like from the FDA is sort of more guidance on the interchangeability and the indication extrapolations as it relates to the issue of switching from biologics and biosimilars.
Yeah, I'll just add, I think that there are, specialist societies are starting to do some work here, but obviously more needs to be done, guidelines to kind of answer these questions, guidelines from the appropriate oversight, physician organizations, and to the kind of value point, there are wide estimates, but most of the estimates are in the billions of dollars of savings range. So even though I completely agree these are not generics, these are biosimilars, they're similar but not, chemical copies of the medicines, they do have the potential to create, significant healthcare savings down the road.
And that biosimilar will lower the cost, but what comparatively lower by how much? That's what I want to know. What is is it 50%, 60%, 90% difference, or only 10% difference? And when you say biosimilar are not the same, they can trigger immune system and lead to consequences that we don't know. But do you have data really to show what is the amplitude of these consequences? What are they for the physician to have an informed decision before switching the medication? If it's just a rash, but that's not a big deal, but it will lead to something more crucial, more interesting, then we have to think twice before we switch.
Well, there's only 2 on the market, so I think it's hard. There are estimates at this point. I've seen tens of billions of potential savings upwards. So there are a number of economists that have kind of estimated the potential savings, but a lot of it is just going to depend on the number of biosimilars that are approved, because as was mentioned, there's currently 2 on the market, and the immune response, I think it depends on the condition. So I don't want to get into dangerous territory being the emergency physician here. I don't know if you have anything else to add there, but I think it's going to obviously depend on the condition, right? So there are some conditions that you would be less likely to have an autoimmune response to, kind of stopping the therapy and restarting it, whereas others, particularly the immune disorders that they're treating, where you would be more likely to see it. But again, I think more work is going to have to be done in that to really spell that out.
Another question?
Good morning. I'm Dr. Latasha Celebi. I'm a family medicine physician by training. And my question is, the focus of this panel is structuring access for our patients, correct? So with the programs such as getting assistance for medication or just educating our patients, what are some of the things that Eli Whitney is doing, or either, not Eli Whitney, but Eli Lilly is doing, and also Pharma is doing, to kind of help providers educate their patients on a grassroots level? And if you don't have those kind of programs in place, what can we as physicians do to kind of help you get those programs in place so you can help us educate our patients about the products that you have, but also about how they can access it?
So certainly from our company standpoint, I think we spend a lot of time and energy thinking about how to help patients better understand their disease state first, and also how to understand the risk and benefits associated with any potential therapies. So that's certainly an area of emphasis for us. So that's in terms of the disease states and the therapies, and also trying to make sure that they're aware of the patient assistance programs and copay opportunities for defraying those costs, so that they're aware of those as well.
How do you, because as a physician, I know that you do have those programs, but patients don't always use them because they don't know how. Do you have anything in place to help the patient know how to apply it and make that a little bit easier for them to be able to get that help with their medications?
I think we do have some programs in place. I'd have to talk to others in the company to better understand exactly, and I can follow up with you to help you understand how your patients might be able to best be made aware of those programs.
And I'll just add to that and say that pharma does really work a lot with patient access groups, and so sometimes that we are able to offer that assistance and educate our patients about those copay programs that industry has and help them navigate some of the red tape that is associated with that as well.
Yeah, I'll just flag the Partnership for Prescription Assistance, it's pparx.com, is a central clearinghouse that we set up, I think about 10 years ago, where our members kind of feed in their patient assistance programs. Obviously, it's challenging because your patient might be on a Lilly product and then a different company's product. So this is a nice way that you could just go there, type in the medicines, and then it'll feed out which links to the right website. Most of the companies participate in that, and so it's a good way to hopefully do a little bit of streamlining.
That's really great. Thank you.
We have 2 more questions. If we keep them brief, because we're getting on the hour, the police.
From Families USA, and I have a access question as well, but a little bit different. And it's one of the challenges that we've been hearing a lot about, and I've actually in my family have experienced, is shortages in prescription medications. So I'm wondering if you're able to comment at all on what AHIP or others are trying to do to address some of these shortages that are impacting a lot of people.
Most of the shortages are for generic sterile injectable medicines, so they tend not to be an issue that we work on from a pharma standpoint, because we are the association that represents the brand, the innovative companies. From an emergency department standpoint, I can say 5 years ago practicing, when I kind of first came out of residency, drug shortages were a huge issue. That I felt kind of clinically. It seems like that, in my just subjective experience working, has kind of ebbed a little bit, but I know that there is kind of, there's the issue of FDA and kind of inspections and inspecting facilities, particularly for a lot of these facilities that are manufacturing like large volume of sterile injectables.
If you go to the FDA site of shortages, there's many that are not injectable. And so I'm just beyond that. There's patches, for example, even extended release preparations of different medications, not the injectables. So I'm just wondering if AHIP have some sort of plan for helping members address that.
I'd be happy to follow up. Unfortunately, it's not an area that my experience is just my kind of subjective clinical one. So yeah, happy to follow up with you.
Last question?
Yeah, that would be short. A question is for Dr. Ybarra, and I am Dr. Ho Tran from the National Council of Asian Pacific Islander Physicians. And we just finished, a 1-year report, to assess the implication of the Health Insurance Act, marketplace, on the providers and patients. So for your slide, about the high peak of the cost, is it concurrent with the increase in the number of the insured with the Affordable Care Act? That's the first question. And second is, another question is about, that when we did our report, we talk about the physicians and with the physicians, and they talk about, the cost, the rising cost of the prescription. And so, for my question to you, it is that, and to Gary as well, it is that how do we have, a discussion, because the cost is not only related to the pharmaceutical company, the industry, but also of the health insurance company as well.
Yeah, that's a great point. So the first piece is the big increase in 2014. My understanding is the actuarial analysis of that is, I think, roughly half of it was due to the hepatitis C medicines that were brought to market. In and of themselves. So about half of it was that. The other half was an increase in kind of access to medicines through the exchanges and the expansion of Medicaid as part of the Affordable Care Act in the first full year that it was implemented. And the second part is, the issue of affordability. which is different for different people, right? Because you could have a patient that's on, a very expensive medicine, so a hepatitis C cure, for example, but their insurance covers all of it, and so it's very affordable to the patient. I've had patients that I prescribe a generic antibiotic for a urinary tract infection for, and they call me and they say, I went to the pharmacy and I have to pay all $150 of this medicine. You need to give me a different one. I can't afford that, and that's a relatively, high value to the system because it's a generic medicine that is relatively inexpensive compared to maybe a branded medicine that I thought I was doing the right thing. I think you're underscoring the challenges that physicians face, which is that we don't often know what a patient's out-of-pocket costs are going to be, and so that I think is an area that we can all kind of work together on, is how can we promote better transparency so that physicians know and can better counsel and predict what the out-of-pocket costs are, so that there's a better linkage earlier on in the process, so that it's not a phone call that you receive the next day or a couple hours later when mentally you've already moved on to your next patient and the other things that you have to do.
Before I thank the panel, I have to ask Congresswoman Christensen, who's here, to stand up, please, everyone. And I want to thank the panel so much for some insightful ideas. Thank you so much.